Let's give it about 30 seconds just because. Okay. Yeah, I now have 8 o'clock. Okay. Good morning, everyone, and welcome to another day here at the Osler Institute's Neurology course. I'm Dr. Mohammed Mahdi Nishatizadeh, and I'm a movement disorder specialist. But I've been involved with this course now for almost 10 years, and I myself took the course when I was originally studying for and passing my neurology boards. So for me, this has been very personal, and I hope that the topics that we cover today and that you experience during the whole course will be helpful for you as you prepare for your own board exam. Now, we're going to start with 3 lectures back to back about the field that I love, movement disorders. And so this first lecture will talk about an overview of movement disorders and specifically highlight Parkinsonism. So without further ado, let's go ahead and get started. If we separate out different types of movement disorders, they often fall nicely into the category of hypokinetic or less mobility types of movements versus hyperkinetic, where you have sort of an increase in movements or um, the appearance of movements that are not normally present. And so I'm going to talk about a lot of these, but I just wanted to have a slide that sort of puts us in the moment and thinks about like what sorts of things that fall under the category of movement disorders. Now, you'll often see at many centers where movement disorder specialists gather and work that the name Parkinson's disease is in the name of the title, and that's not for mysterious reasons. We often see that the number of people who have Parkinson's disease or Parkinsonism is a significant number of the patients within a movement disorder clinic, whereas some of these movement disorders that are listed here may not be as common. But it's still important to know because even as you know, rare disorders in which details are often studied or known are fair game for the neurology boards. So when we think about Parkinsonism in general, this is often a condition that's associated with more advanced age. And sure enough, people over the age of 60, the incidence is reported to be about 1%. And another older study found that people over the age of 65, it's more like 1.5%. And then as we approach age 85, as many as 4% of people are Parkinsonian. Now, there was a study in the past year funded by the Parkinson Foundation, which looked at what is the incidence of Parkinson's disease in the United States. And they found that the overall incidence may be underestimated by 50%. And so, this is a huge increase in the overall number of people who may be Parkinsonian over time. When we talk about Parkinson's disease, this is the specific condition where it's primary Parkinsonism. It's thought to be idiopathic. Now, the problem with the word idiopathic is over time with science and research, we often find that a clinical problem is due to something. But the idea with Parkinson's disease is that it's not a very clear or obvious secondary cause involved, like some of the other conditions where it could be environmental due to medications, for example, or known like cerebrovascular disease causing vascular Parkinsonism. And so just your idiopathic regular Parkinson's disease explains about 75 to 80% of all people who are Parkinsonism. When people do have secondary Parkinsonism, it's more often that it will present as a new onset after age 70. And I've seen many patients over the years who are told that they have Parkinson's disease, but it didn't start until they were 75 or 80. And almost always with a careful history and consideration of many of the secondary causes of Parkinsonism, you can find sort of a better reason why they might have a secondary Parkinsonian cause. For example, vascular Parkinsonism or dementia with Lewy bodies is often underappreciated or underdiagnosed because maybe the cognitive deficits that precede the Parkinsonism may be very mild. Even essential tremor, as people get older and they have more and more cerebellar atrophy, there's one theory that says that this can sort of unmask the amount of loss of dopamine that everybody goes through very gradually just decade by decade with aging. Parkinson plus syndromes we'll also talk about, but rather than just classic substantia nigra loss of dopamine, multiple systems often degenerate. These could involve the higher level cortex, other structures in the basal ganglia, other brainstem nuclei or connections, and even cerebellar fibers and pathways. Heredodegenerative Parkinsonism is another group of Parkinsonian conditions. Sometimes people who present with idiopathic Parkinson's disease can have genetic risk factors, causes, or triggers. And so this is sort of a complicated area because 15 years ago, when I finished fellowship training, it was estimated that 3 to 5% of all Parkinsonian conditions were due to a genetic cause. But it turns out that with multiple genetic risk factors and complex genetic interactions, um, as many as 10 to 15% of people might have a hereditary or genetic cause of Parkinsonism. Now, the classic story with that is that people who had more young onset Parkinson's would be more likely to have a genetic trigger, but it's not that simple. There may be people, for example, who have a strong family history of some Parkinsonism that shows up late onset, potentially after 65 or 70, but it's a very mild thing. And so it takes time for the brain to change until those symptoms show up later in life. And then there's a group of benign Parkinsonian conditions. Probably one of the most famous ones is benign tremulous Parkinsonism. I'll never forget that I saw a patient about 6 years ago who he was still walking, and I met him for the first time in clinic. And I asked him how long he had features of Parkinson's, and he said 35 years. And so that's a very atypical course where he's still ambulatory, still moving, not having things like levodopa-induced dyskinesias. And I think that's would be still very responsive to levodopa. This is a condition which may involve um, sort of starting off with low dopamine and then progressing at a rate that's more consistent with normal aging rather than a neurodegenerative process. And then it's always important to consider dopa responsive dystonia because these are often people who, um, are even very low doses of levodopa, even once or twice a day, will have quite a bit of improvement. And, it will be thought that they're Parkinsonian. So a little bit more focus on primary or idiopathic Parkinson's disease. Again, 75 to 80% of all Parkinsonian types, but sometimes Parkinson's disease itself can be categorized into subtypes. And so probably one of the more famous ones would be tremor dominant Parkinson's disease. And so this is sort of what a lot of non-neurologists think of with Parkinson's, where you have rest tremor, usually affecting, the limbs or appendicular structures rather than the midline axial structures. So there may be rest tremor. Some people may have a very small amount of action tremor, especially like postural tremor, usually with a little bit of latency. But these features are more obvious than any minimal or mild amount of bradykinesia or rigidity, especially usually early on. And when it starts more in the limbs rather than in the midline axial structures, you could imagine that mobility overall may be better. And so the overall prognosis over many years and decades tends to be better, even though there may be very many variables involved in progression. A lesser known type is the postural instability gait dysfunction type of Parkinson's disease. And so this often affects more axial or midline structures. If I sort of just take it from the top, people are more likely to start off with cognitive issues earlier on. They might, for example, may have eye movement abnormalities or more disproportionate difficulty swallowing. Their truncal immobility may make it very difficult for them to roll over in bed, even at the beginning stages of Parkinson's. Many of them may not even have tremor, which can delay the diagnosis because I thought Parkinson's disease was a tremor condition. And so as many as 15 to 20%, maybe even 25% of people with even classic Parkinson's disease may not have tremor at all, or not for many years into the course. Or maybe they have a little bit of tremor, but not your classic pill rolling rest tremor. And so, as you can imagine, once people have cognitive or swallowing problems that could risk aspiration, or they're having more truncal immobility, the likelihood of earlier postural instability and falls can be associated with a worse overall prognosis. Even midline structures like the urinary bladder will be disproportionately more likely to retain urine and lead to pyuria or even full-blown urinary infections, which can result in hospitalization and further decline. So, there is a lot of variability. There may be some people with Parkinson's disease who have a younger age at onset, and some of them, many of them may have a slower disease progression. That's not always true. But then there are also these subtypes of people who are older, who have more of a rapid disease progression because they've lost other cognitive reserve or neurological ability to navigate progression. And so the decline may be more steep. But then we also have people who have an older age at onset and they have less of a neurodegenerative process, and then they can change more with normal aging, like I was talking about with, for example, some folks who are really advanced in age who have essential tremor. And you can see them, follow them over 5 to 7 years, and they don't need more and more levodopa. And, I always remember that patient who was real pleased with his Parkinson's because, the medications were working beautifully and he didn't have a lot of the motor fluctuations or dyskinesias. Let's talk a little bit about medication or drug-induced Parkinsonism, because if you look at the numbers overall, there's some variability worldwide about how widespread this is, but some of that also correlates with the frequency and availability of medications that can trigger uh, drug-induced Parkinsonism. So men tend to have a 40% higher risk, and it's not clear whether that's just because of dopamine factors or whether estrogen is a weak dopamine agonist might be protective, or whether it's just the use and prescription of, um, for example, dopamine antagonists. We know that, for example, older women are more likely to develop tardive dyskinesia, where people get involuntary movements of the mouth, lips, and tongue. But it may be that, for example, men are more likely to develop just dystonia or Parkinsonism. And so people who are older, who are 75 and older, there's a more than twofold risk of developing a drug-induced Parkinsonism. And some of that may be involved with chronic kidney disease and the inability to clear out some of the direct dopamine antagonists or their metabolic byproducts. And so you see, for example, in Europe, there's almost threefold risk of this versus 1.8-fold in Africa and 1.5-fold in Oceania. But then in Asia and the United States, in comparison to the rest of the world, overall, there's about a 45% lower risk. Some of that may also involve access to the newer second generation medications that may be less likely to be involved. But if we try to convince ourselves that this is not a problem using the newer medicines, we would be amiss because there are certainly second generation dopamine antagonists that I'll talk about that can increase the risk of medication or drug-induced Parkinsonism. Let's go over some of the different types. I'm not sure how much they will get into all of these different structures of dopamine antagonists, but I thought we could sort of organize it a little bit. So as you can see, there are phenothiazines, and many of these are some of the older original dopamine antagonists used for psychosis, for example. Sometimes psychiatrists will use these off-label for atypical depression as well. But some of these even are no longer available. But they include things like chlorpromazine, thioridazine, I don't think they make anymore. Flufenazine is sometimes used in children or teenagers with Tourette's, for example. Perfenazine, and then prochlorperazine, often used for migraine with or without nausea or vomiting. The butyrophenones include haloperidol or droperidol. The thioxanthines, the one that comes to mind is thiothixine, which is a very old antipsychotic. And then the benzamides include metoclopramide, which is actually historically used for things like gastroparesis, the most common cause of drug-induced movement disorders. Amisulpride is another benzamide that was FDA approved in 2020, specifically for the indication of postoperative emesis. And for example, N-methyl amisulpride, or LB-102, is not even available yet, but is currently being studied as a more lipophilic agent for schizophrenia because it has better blood-brain barrier permeability. So I want you to notice that even though there are different names for structures, those structures don't help predict the clinical usage or the way these medications are prescribed or certainly FDA indicated. And there can be a lot of off-label use. These are sort of the four categories of dopamine antagonists or dopamine receptor blockers. All right, what about the second generation or atypical dopamine antagonists? The idea here is that they're less likely to bind to